You obviously can't make this table until you decide what DRGs go in which boxes, and obviously this is more illustrative than it is actual, I trust.
Yes, and I think I think this discussion has been very good. Some of the things I took away from it were, and I know you've mentioned this particularly too before, John, but the vertical axis around the diagnosis-based severity level, I think this is one that certainly as the payers get into the data, and to your point, look at what some of the cost curves look like, there are absolutely going to be refinements and additional adjustments to it. I know Medicaid, for example, is looking at both groupings from the APR as well as the MSDRGs to understand how that would impact the distribution across some of these and how to potentially build that in. I would also, to your comment before on the gestational age within, say, the 29 to 34, look, each one of these cells, you can think of it as an episode. So neonatal is going to have multiple episodes versus some of the other medical episodes that have launched are one episode. And within each of these boxes, there's going to be adjustments for age and all those things. So a 29-week medium severity baby, however medium severity ends up being defined, versus a 34-week medium severity baby, they will have adjustments on age to account for the fact that that 29-week baby is going to need to be in the NICU or in the nursery longer than a 34-week baby. So there are going to be adjustments and exclusions, the same as has been applied to other episodes, but for every single one of these individual boxes on the page.
And we've been kind of talking about these boxes for a while, but you can see 24 versus 26. Again, that's the distribution of the Blue Cross data. And if you flip back and forth, they are pretty comparable, with the exception that Medicaid had a bit more on the top line, some shifting on the top line. But for the most part, the numbers are pretty similar. And then you have on slides 25 and 27, you have some cost data for Medicaid. You have the relative percentages for Blue Cross data based on a baseline of the lower left corner. And again, there is a fair amount of similarity between the two frameworks, between Blue Cross and Medicaid, in terms of how the costs distribute. So there's consistency across the two payers. What we've seen here is the kind of the framework of how we would start looking at the distribution of the work that's being done, and then a framework to begin, as Dan said, to develop sub-episodes where you can compare practice variability and differences across sites in terms of the delivery of care. David?
Just a last comment on the dating. Arkansas Department of Health and most states nationally have now switched from using last menstrual period for dating purposes to clinician estimate, and it's been shown to be much more accurate. Most women, at least 80%, get in for their first visit in the first trimester. Ultrasounds at that time are typically plus or minus a week. So if that's compatible with the last menstrual period, then that's the confirmed. If it's not, then we use the ultrasound estimate. The only time there's a problem is if you get into second and particularly third trimester for their first visit and their ultrasound, it's going to be totally inaccurate because it's plus or minus 3 or 4 weeks at that point.
Yeah, I think just very briefly, slide 28 just kind of gives you some examples of the different kinds of severity and the different kind of gestational age. And thank you, David, for those comments. And then on page 29, kind of shows where we might have episodes of care, because you get to the very, very high complex cases, the potential for very unusual one-of cases starts to kick in, and you have a lot of outliers.
It does seem to me that you have the quality is a floor, and if you're going to set it so that it isn't prohibitive for most people, it's not going to be a particularly high-level floor. And there's no advantage to people who are delivering higher quality up and beyond the floor. And it would seem to me that would be something that would be worth adding to your equation, bonus points or something.
So the question is, in terms of quality and the floor, one could argue that if you are not, in the other episodes of care, we have required some demonstration of achievement of certain quality metrics in order to qualify for gain sharing, so that you couldn't just have a low-cost operation without providing at least some demonstration that you're meeting some nationally recognized performance activities. In something as complex or potentially complex as the more complicated neonatal care, one could assume or one could think that if you have lesser quality processes in place, that you would probably have increased costs or more or different outcomes or more readmissions, so that cost and quality may go hand in hand. So we are going to have some quality metrics built in, but I would think that some of this would reflect the fact that I would assume that in some of these instances, the appropriate provision of care would probably result in competitive or lower costs than if you have a complex child getting cared for in a less than quality way.
On both 24 and 25, there's a reference to outliers with costs greater than 3 standard deviations. Do you have any idea at this point how many of those there will be?
I think that will all depend on, as the payers refine the diagnostic levels to make the matrix, obviously then the number of outliers would vary depending on how that is. But in most of the other episodes, which sometimes don't have quite the spread as neonatal, there have been a handful of outliers above 3 standard deviations in every single episode, even after you apply a number of clinical exclusions for very severe conditions and so on. So those are still there, and those would get removed even after you exclude kind of the more severe cases.
And it may not be an outlier at that site. It'd be an outlier compared to everybody else. So just because you have a very expensive child at your place, it may not be an outlier in the whole system for that episode.
On the overall episode design, the construct of it, which Bill mentioned briefly, the episode would begin at the time of a birth, a live birth. It would continue through discharge from the facility, whether that was the facility of delivery or in some cases when a neonate has been transferred to a higher acuity facility, the episode would continue through discharge from overall NICU care or nursery care, and there would be a window of time after that discharge. The payers haven't made a determination exactly out of what that time is, whether it's 7, 14, 30 days or longer. And in the time frame, so anything from the birth to discharge from the facility, all inpatient, outpatient, professional fees, anything else associated with diagnostics and labs, which are going to be typically built into some of the charges already, all those things would be included in when calculating the average cost of the episodes. The outpatient portion, after there's the neonate's discharged from the hospital, the goal is also to include a set of related outpatient services as well, whether that be visits to the pediatrician, our pharmacological treatment, and also readmissions back to the facility. The idea and the goal is really to incent kind of coordinated care of quality for a duration for the unit, including for a set amount of time post-discharge. But that is the construct so far, and again, the details are still being fleshed out as the payers refine the matrix you saw before, and therefore what the historical costs look like, and so on.
Yeah, I'm just a little bit confused. If we have a baby we take care of for 80 days in hospital and send them home, we typically have their general pediatrician, their primary care doctor, see them within 48 to 72 hours. But we as the neonatologists have no input in what's done at that visit or any of that. So you're saying that that's going to be part of this bundle, part of this episode of care?
Whit and Chris, do you guys want to talk about some of the debate that we had as a group?
We had a lot of debate, actually, kind of alluding to that, on how long the episode, when the episode ends after discharge. Some concerns were, if a preemie's discharged and then goes to Walmart the next day and gets RSV and then has breathing difficulties and comes back, is that really part of this episode, or is that a new episode? And we're actually still debating that now. We would love to have feedback or some of your opinions on how long the episode ends. But you're exactly right, and we have not actually talked about if that's part of this episode or not. But they think that a good follow-up system, if you are communicating well with your community pediatrician and having good communication there, and the baby does follow up, that could actually improve. Make sure the baby's feeding well and gaining weight. That could improve the care and actually decrease the readmissions and some of the complications.
So as the neonatologist, if my group is the principal provider, then the pediatrician is...
So you're saying if we order a lot of tests at our visit and drive up your costs, it's going to reflect on your episode?
It just ties us together in a very unnatural way. We're getting it on the front end, too. I mean, Whit would attest to this. The decision to give steroids or not impacts the baby's course and morbidity percentages and mortality, and I have nothing to do with whether that steroid shot is given or not. So, again, an unnatural tying together.
But down the road, I mean, that's part of what we're doing here, in that, we have tended in the last 2 decades to work in silos. And it's time that we need to work more as a coordinated team. And yeah, there'll be some episodes or some locations where things may not be as integrated and coordinated as it should be, but that is part of the challenge of this, and that the places that are doing it well will be rewarded for it, and the other folks, they may need to have some conversations with their colleagues.
What I would also add is in our discussions with clinicians across the state and also neonatologists and pediatricians across the country, folks will indicate, if you even take the question of how long is that post-discharge window, ideally, how long would that be? I think folks always start at a place of slight discomfort because of, the baby's leaving and being discharged from the facility and the care is being taken over, say, by a pediatrician or a primary care physician. And then the question always comes, well, are there cases in which if you have a facility or neonatology group working together with a facility that invests in, certain ways to coordinate care and ensure there's a handoff with an outpatient pediatrician and therefore has a lower readmission rate and better outcomes than another neonatology group or facility, should the payers really be rewarding and kind of creating incentives to change the system in that way? And I think that's part of what the payers are trying to explore here with input from this group as well. So you'll see again that the decisions haven't been made of exactly how long the window is, but you can get a sense of the sorts of questions that the system is thinking through. See another question in the room and then one other.
So just looking at the data, we have about 37,000 deliveries in the state. These two payers represent 10 and 65% respectively based on the data that's presented at this meeting. So about 75%, about 3/4 of the deliveries in the state. And one of the slides alluded to the poor rural nature of the state. And I would throw out that this follow-up is complicated by that demographic across the board. We've had very complicated babies that we've had to send home, no medication, no monitoring required, and the baby's discovered, under the mother because she slept co-bedded with the infant, although that was advised, gone over, reinforced, and so I'm just reflecting back on that demographic and that we need to keep that in consideration as you define these episodes and be very strategic about how you do that.
Thank you for that comment. There's a comment right here.
Will this model anyway incentivize, and I hope not de-incentivize, newborn screenings, be they the metabolic screening and the hearing screening, because those are something that could be left off to decrease the cost, and those are shown to be very valuable.
That's what we talked about earlier. You make sure that you have a certain percentage of, 90% of the kids have to have that done. So, or pick a number, and so may not ask for perfection, but we ask for some pretty good performance. And getting back to the other comment about, the variation of what happens when the child goes home in the family environment. This will be true for all the providers. Everyone's going to have those kind of situations, and it's, in some place again, the episode of care framework is based on the average episode of care. It's not based on an outlier episode here and there. It's based on what happens on your book business as opposed to every single case.